morning to everyone. So we are starting, the Neuro Ophthalmology session. So I would like to invite Dr. Rohit Saxena as a chairperson of this session, Dr. Sucheta Bariza as a co-chair, then Dr. Virender Sachdeva. I think he is on the way. He'll join very soon with us. And I would like to invite Dr. Manjushri Bhate, who is going to moderate this session. So over to Dr. Manju Bhate.
Okay, good morning everyone, and thank you very much for joining our session today. So we will start with, we have 8 speakers, and each talk is going to be 7 minutes, and we'll try and adhere to the timing. So can I invite Madhuri Venigala to start with neuro-ophthalmic examination?
Good morning all. At the outset, I thank AIOC and APOS for giving me this opportunity. It's a broad topic. I try to brief up the examination. In neuro-ophthalmic examination, you find what you look for and you look for what you know. So William Osler's famous quotation is, listen to your patient, he is telling you the diagnosis. The history taking is very important so that we focus the examination for the topographic localization and probable etiology of the lesion. So the presenting complaints of the patient can be varied. It can be a loss of vision, double vision, or any associated CNS symptoms. In the blurred vision, the history is to be taken very carefully, whether it is monocular, unilateral, or bilateral. Monocular vision loss is more in favor of a pathology anterior to the optic chiasma. If it is a bilateral, it can involve both eyes, or it can be an optic nerve disease, or it can be retrochiasmal. If the onset is sudden, usually it goes in favor of ischemia or inflammation, that is within hours or days. If it is gradual, progressive, coming into months to years, it can be a compressive lesion like a tumor. And they can be associated some phenomenon like blurred vision more in hot bath. It is more of in favor of demyelinated diseases, which is an Adhoff's phenomenon. And if it is associated with pain, usually it goes in favor of optic neuritis or associated demyelination. It is a painless, more of ischemic origin. And they can be associated temporal artery tenderness in case of giant cell arteritis. If there is associated pain on ocular movements, usually it goes in favor of optic neuritis. They can be associated redness or photophobia. And if the visual obscuration is transient and if it is in seconds, usually it goes in favor of papilledema. If it is in minutes, it can be DD can be emboli or ischemic pathology or can be migraine. So the history also includes a past medical history of any systemic complaints, any drug intake like OC pills. And after that, go for general examination. So we have to see the behavior of the patient, his orientation, higher functions. Gross systemic examination, more emphasis on the CNS examination, cranial nerve, sensory, motor. And in the motor, see his gait, his reflexes, tone, and power. It's a case of a small child whose parents brought the child, a 6-month-old child, for the right eye proptosis. And the MRI scan, it is found to be an optic nerve glioma involving almost all the visual pathway. So in the ocular examination, it depends on the case to case. In general, I'm briefing about all conditions. First, look for the head posture. Next is a facial symmetry. And go for extraocular movements, both uniocular and binocular, both ductions and versions. And to help sensory evaluation for stereopsis, Wirth 4-dot test, cover-uncover test if it is a strabismus case. So the head posture can be normal or it can be anomalous. It can be tilted or elevated with chin depression or elevation or head tilt. It can be in favor of paralytic strabismus. So both ductions and versions in ocular movements have to be seen in all 9 cases. And in the anterior examination, particular emphasis is to be given to the pupillary examination. So it is a demonstrated thing is the swinging flashlight test, where RAPD is observed in the case of right eye. As a torch is being swung from the normal people to abnormal people, the right eye is getting dilated. Both direct and concentration light reflexes and accommodation reflex is to be tested. And coming to the fundus, the optic nerve, the optic disc, the margins, the details have to be carefully noted. So in the CNS examination, if you feel the systemic involvement is there, grossly have to examine all the nerves for the smell, olfactory, for nerve palsies, for any loss of taste or wasting, and even for auditory nerve also. And coming to our visual loss, detect and quantify the visual loss, we have some special ancillary tests apart from this lens, like color vision, the visual fields, photostress, contrast sensitivity. Like in the visual acuity, you have to examine the patient whether he has any eccentric fixation or he has any missing letters on either side of the chart, or is there any metamorphosis uniocular. To go for the color vision, we have to go for the Ishara chromatic charts. More it's in favor of compressive neuropathies or inflammation or ischemic optic pathology. And contrast sensitivity also has seen lowest amount of contrast needed to see a grating has to be examined. And photostress recovery test, normal it is less than 60 seconds. Usually it goes in favor of maculopathy where it gets prolonged. And visual field testing, it helps to localize the defect along the visual pathway and to quantitate a lesion and measure defects over time. It can be seen in the bedside or in the clinic by confrontation or even by perimetry. So the defects will be as it can be an enlargement of blind spot, a central scotoma, or bitemporal defects involving the optic chiasma. So it's a gross small nomogram like. It is a bitemporal field defect. Usually it goes in favor of chiasmal lesion. So based on this, we can investigate the patient. So can be progressive optic neuropathy, can have many of the causes, like can be bilateral, can be glaucoma, or can be nutritional or post-toxic. If it is, depending on the case, we have to modify our examination. If it is a paralytic strabismus, we have to think in case of whether it is neurogenic or myogenic, like involving the neuromuscular junction, which is common, is the myasthenia. And if it is an ocular deviation has to be seen in different gaze positions. In paralytic, we expect secondary deviation more than the primary deviation. And to avoid diplopia, the patient can have even compensated head posture also. It's a case of right oculomotor nerve palsy. So in the binocular diplopia, we get uncrossed in sixth nerve palsy, where it is crossed diplopia in third nerve palsy. So the double vision, we have to note the history, whether it is monocular or binocular, in which direction it is moved, whether it is constant or fluctuating, horizontal, vertical, again any symptoms are there. So there's many nomograms like this. And with a patient with anisocoria, we have to see the midriasis of the abnormal pupil, whether it is in light near dissociation is present or it is absent. Usually if it is a denervation hypersensitive with 0.1% pilocarpine, if it constricts, it goes in favor of eddy-stonic pupil. If there is no response with, and if you add 1% pilocarpine, if it is constricting, it goes in favor of third nerve palsy. So small irregular pupils with light near dissociation goes in favor of Argyll-Robertson pupil. And if it is normal light reaction and this constriction is more with hydroxyamphetamine, it goes in favor of Horner syndrome. So special tests like force duction test can be done on topical anesthesia to rule out the restricting pathology. And tensilon test will be positive for myasthenia gravis. So depending on the choice of differential diagnosis, a type of lesion suspected, we can investigate the patient apart from HFA and OCT, whether CT or MRI, which is more specific, can be ordered. And CSF analysis also can be done in IIH. So take home message, detect etiology, detect, quantify and localize. Prompt diagnosis and treatment can restore vision to the patient. Thank you.
Thank you, Dr. Madhuri. That was an excellent presentation, very nicely covering the key aspects of a neuro-opthal examination.
Thank you,
I
sir.
think we'll go on to the talks, and then subsequently, as per the availability of the time, we will discuss if there are any questions. So the next speaker, Dr. Gaurav Sharma, he'll be presenting on confounding case scenarios in neuro-ophthalmology.
Thank you, sir. Good morning, everybody. I'll be speaking on confounding case scenarios in neuro-ophthalmology. The first case is one which made my neurologist friend very confused, and this was a 30-year-old patient who was having headaches, and the neurologist was had been referred by an eye surgeon as a case of papilledema, and even multiple fundus examination all showed that the patient was having papilledema, but since she didn't fit into the criteria of IIH and MRI was normal, the patient was referred to me, and when I examined, I looked at the fundus, and it looked like the disc margins are blurred, but you can see that this kind of a nodular protrusion over the disc was there, and also you could trace the vessels very clearly over the disc margin. So it was not a case of true disc edema, it was optic disc drusen. So optic disc drusen should be kept in mind, and with the possibility in patients with papilledema, you should not mention papilledema in such cases, because the neurologist would then go for overall investigation, even invasive ones. So OCT also showed some hyperreflective bands suggestive of optic disc drusen. The second case was in fact a case series of patients who presented recently, around 2 months back to me, with almost similar clinical picture of unilateral disc edema with hemorrhages around the disc in patients who were both hypertensive and diabetic, and with a similar kind of vision loss. And this patient, male patient, had 660 vision on right eye and 618 on left eye. The fundus examination, you see in the right side, the hemorrhages confined to area around 2 disc diameters around the disc only. Left side, it was looked like a picture of grade 3 hypertensive retinopathy. So was it papilledema, grade 4 hypertensive retinopathy? The blood pressure was not very high. The neuroimaging was also normal. The patient was lost to follow-up initially, and when he came back after a few weeks, he had optic atrophy and PL positive vision on the right side. The second patient was a female, again similar 6/36 vision, and the fundus examination, again intense hemorrhages over the left disc on the left side and some venous tortuosity, but the other eye was absolutely normal. Is it CRVO? But not a classical picture of CRVO. The hemorrhages are not that much extensive and confined around the disc only. And the third case, again this patient hemorrhages around the disc but sparing the temporal part of the disc, more on the nasal side. And the fourth case, again hemorrhages near the nasal side, sparing the temporal side. So all these 3 or 4 cases had similar clinical picture, were all hypertensive and diabetics. So what was the cause? Was it a severe NAION, or was the patient having some complication because of combined use of these newer anti-diabetic drugs and calcium channel blockers? Calcium channel blockers are known to cause it, this NAION, but these drugs were also common in these patients. We're still looking for what is the cause for these patients. Now, this case was the third case, was referred to as a simple case of optic neuritis from the field, and looked like optic neuritis as a 30-year-old patient with RAPD and 5/60 vision. And you can see that there is a disc edema, but this area just around the disc on the nasal side of the disc attracted my attention, and we investigated. Look, it was found to be a choroiditis patch, and investigated for tuberculosis and put on ATT and steroids. So this was a case of juxtapapillary choroiditis with neuritis. Now this patient was presented to my resident with the history that she cannot see the stairs while walking downwards, and so my resident investigated for the visual fields and found there was an inferior altitudinal field defect, and brought this patient to me as a case of NAION, possibly NAION. But she had omitted the dilated fundus examination, and you can see that this is a case of hemicentral retinal artery occlusion. This girl was found to have SLE as a cause for this vascular occlusion. The same resident, few weeks later, again had another patient, 33-year-old lady, with again similar complaint of inferior field loss, and this was the visual field, and this time she dilated the fundus and found that there was again a hemicentral retinal artery occlusion in this patient. So always do a dilated fundus examination before making a diagnosis of a neuro-ophthalmological disease. Now, sixth case was a patient referred to me by the neurologist. He had stroke and neurological deficits, and neuroimaging showed infarcts in the different areas of the brain, in the parietal lobe and the temporal lobe. But on examination, we found that he had a right homonymous hemianopia, and the dilated fundus examination again in this case was undertaken, and we could see these small dot hemorrhages in the mid-peripheral retina, suggesting a possibility of ocular ischemic syndrome. So we advised CT angiography, which showed that there was a non-opacified CCA and left ICA with formation of ECA by collateral. So we could get the cause for the stroke in this young patient. Now this fifth case was a paramilitary personnel, and he was labeled as a malingerer. First, he was shifted from field duty to office duty because he said, I cannot do my work properly. He's always had a 6/6 vision. And even in office, he said, I cannot do. So he was referred to me as a possible case of malingerer. When I asked him, he said, I cannot localize the files which are present on one side. So when we did the visual fields, we found he had a bitemporal hemianopia. So he's certainly not a malingerer. And neuroimaging picked up this craniopharyngioma in this patient, and this is an intraoperative picture of this patient being operated, and both his sight and vision and life was saved by timely intervention. Now this case, I know slides are moving forward. This case was a patient came to me from a peripheral area, very far flung from my center, and he had vision loss affecting one eye, finger counting at 1 feet. Pupils were sluggishly reacting. There was anisocoria, and there was some mild proptosis and restriction of adduction and elevation. So we suspected possibility of a lesion near the orbital apex, and we admitted this patient in our ward. And since he was, he had planned a neuroimaging and orbital imaging, but since he was admitted with us, we decided to do the visual field of the other eye, And we found that this patient had a temporal field defect on the left side. And therefore, we changed our plan to neuroimaging to brain imaging, and we found that this patient had a pituitary macroadenoma with this figure of 8 kind of appearance and compression of the chiasm with intratumoral hemorrhage. So that's all. Thank you for your kind attention.
So thank you, Gaurav. That was an extensive presentation where you have taken into account all the presenting features. And neuro-ophthalmology as such is not only ophthalmologist, but you have to take into consideration other specialists, maybe a radiodiagnosis and a neurologist into the account. So now I call upon Dr. Virendra Shashdev to present on optic neuritis in 2023. What do we need to do for my patient?
Dr. Virender is an outstanding neuro-ophthalmologist. In fact, we always get amazed by his depth of knowledge, and his presentations are always wonderful. So thank you, Dr. Virender. We'll be looking forward to this talk and many from you.
And thanks, Dr. Rohit, for so kind words. We'll be talking about optic neuritis in 2023. What should we be doing for our patients currently? As we know that optic neuritis is one of the most common diseases that we come across both in ophthalmology and neuro-ophthalmology setting. So let's see what we can do. We all know that optic neuritis refers primarily to optic nerve inflammation secondary to demyelination. It can be clinically isolated syndrome without occurring in association with a systemic demyelinating disease or as a part of another demyelinating disease, most commonly being multiple sclerosis, acute disseminated encephalomyelitis, neuromyelitis optica, or MOG optic neuritis. We also see a fairly large number of patients who have a para-infectious or post-vaccination optic neuritis in India. So let me take quickly through a couple of scenarios. So this is a patient who had a decrease in vision in right eye following a viral illness 20 days prior. No other systemic relevant history, but marked decrease in vision in the right eye. We see a RAPD grade 3 in right eye, and we can see that the fundus picture looks normal. So given this scenario, you are thinking most likely of a retrobulbar neuritis and possibly post-infectious because there was a history of fever. We see the characteristic signs on the MRI. We can see optic nerve swelling in the right side with post-contrast enhancement. MRI brain was normal. You can see in some cuts, and the rest of the other sections also was normal. So patient was treated with injection IV methylprednisolone for 1 gram for 5 days, and 2 weeks later the patient had remarkable recovery of vision, color vision, RAPD was resolving, and we can see that disc shows small pallor that is developing. Over a period of time, this patient never developed any recurrences or neurological complaints. So this would classify as a clinically isolated syndrome or an isolated demyelinating optic neuritis. If you pay attention, over a period of time, the patient has also remained normal. So that I believe that we can make the diagnosis of clinically isolated syndrome in prospective after following the patient for some time. Let's take the other example. This is a 25-year-old woman who presented to us now with subacute decrease in vision in left eye for 1 week. There was no frank pain or pain on eye movements, but there was some periocular discomfort. No other history of vaccination, trauma, or neurological complaints. So this is the fundus picture of our patient and the examination. We have marked decrease in vision in left eye. Surprisingly, no RAPD. In the right eye, which is 20/20, we can see color vision is 10 out of 70. If you pay attention, we can see a mild hyperemia in the left optic nerve. There might be subtle pallor here, and definitely right eye shows pallor, which is more evident on the red-free photo. So given this is a patient with optic neuritis with coexisting pallor. So it tells that it is not the first episode. This is the second episode of optic neuritis. Even the visual function, like with visual fields and VEP, showed abnormalities in the right eye as well, suggesting that right eye also is having a subclinical disease. So we do MRI like we do in all patients of optic neuritis, and we can see contrast enhancement in the optic nerve, as well as we can see characteristic demyelinating lesions which are arranged perpendicular to corpus callosum, also called as Dawson's fingers. This is a patient of multiple sclerosis. And we can have multiple sites where characteristic lesions can happen, like in periventricular, subcortical, areas, and we can also see sometimes old lesions which do not enhance on contrast. So this is a patient with multiple sclerosis, which is the second common disease that is described. The third scenario could be that of this patient who is previously diagnosed to have multiple sclerosis and now comes to us with decreased vision in both eyes for 2 days. Past history is very significant. 3 episodes of neurological complaints. First time in 2003 with good recovery, then in 2004 with third cranial nerve palsy, and then in 2006 recurrent episodes of ataxia vomiting again improved with IVMP. Following this, the patient remained in remission for long time. At presentation, there is marked decrease in vision in both eyes, there is pallor of discs, and there is constriction of fields on confrontation, which is only possible with counting finger vision. So we diagnosed as recurrent optic neuritis, possibly MS, which the patient was carrying, and to diagnose further, we did MRI brain and orbits with contrast. Surprisingly, none of the lesions like the ones we saw before, and we can see only the hyperintensities in the optic nerve. So we went ahead and did the MRI spine, because in recurrent disease it is very important. So we found that there is characteristic lesion which is extending from the middle of the cervical segment towards the thoracic segment, longitudinally extensive transverse myelitis, and the patient was investigated for NMO antibodies and they were positive. So the diagnosis was revised to NMO. So, and the last case is this one of a young patient who presented to us with left eye optic neuritis first time. Also the patient had recent onset seizures with the RAPD. So there is definite disc edema. The MRI showed presence of optic nerve lesion in the left side, but rest brain was normal, and there was good recovery with IVMP. But over a period of time, the patient went on to have a recurrence in the right eye. So young child presenting with recurrent optic neuritis, you go and do the MRI again, and you can see that apart from the optic nerve lesions, you can also see the characteristic lesions which are occurring in the involving the chiasm, optic tract, and the large lesions which are in the brain parenchyma. This patient is most likely to be MOG, and this was positive. So why it is important for us to distinguish? Because each of these diseases, as we can say, they can have recurrences, progressive neurological disability, and we need to treat the underlying disease. So in today's scenario, we work up with this guideline. We try to look at distinguishing features, like in MS, it is more common in females and adolescent and young adults, and they never present with those big lesions. MOG, there is a separate class, I will separate talk, I will not go into detail, but the studies have shown that MOG optic neuritis tends to occur more commonly in younger, tends to have one episode usually, though recurrences are described, whereas NMO can also happen with transverse myelitis, clinically isolated syndrome other than optic neuritis, and area post-Riemann syndrome. So what should be our workup? Today we do workup to document visual function, document the damage with OCT around 3 to 4 weeks of episode, but most importantly we do the MRI in the first episode only to find out what are the lesions. So this describes the classical lesions like in MS, where you have unilateral short segment involvement, spinal segments are involved in the thoracic area, and periventricular lesions. MOG can have bilateral lesions and ETM in the cervical cord, in the lower segments, whereas NMO characteristically involves bilateral long segments, might involve chiasm, longitudinal extensive transverse myelitis in the thoracic and the cervical segments, and periependymal lesions. This should also be backed up by a further workup with serology to look for NMO and MOG antibodies. And if you are suspecting a recurrent disease, always obtain a MRI spine also. That can help. CSF analysis should ideally be done in all patients according to the neurology and the existing literature, but wherever you are suspecting multiple sclerosis or something different. I'll skip about the role of OCT, but just highlight 2 more points. Role of OCT angiography is not needed specifically in all patients, but when you have confusion like patient presenting with papillitis in extremes of age, you can use OCT angio, which will not show a lack of the perfusion deficits in optic neuritis. And last point is treatment guidelines. We start treatment with IVMP like previously told in ONDT, but most of the times we do 5 days, and based on the underlying diagnosis like MS, NMO or MOG, we give that definite treatment like interferons or Copaxone or other oral drugs for MS, enema and MOG, azathioprine or rituximab are preferred, and for MOG it is IVIG currently. So in lack of time I'll stop here, but just I would like to stress that it's a syndromic presentation. You need to define what it is. It is optic neuritis in setting of which disease. Define the syndrome, do imaging, serology, and manage appropriately. Thank you.
Thank you so much for so lucid and the wonderful talk. I think you tried to cover the all aspects of optic neuritis. I think what we need to understand is it's not just an disc edema and treat it with the steroids. So it has been evolved over a period of this last decade and half. These entities can be classified as he has rightly mentioned. These 4 entities we need to keep in mind and accordingly investigate and treat, because if you diagnose it properly, then the treatment is completely different, and it's kind of a vision saving. So thank you so much for a wonderful talk. I would like to invite Dr. Dvij Saha. So he is going to talk about eye as a window to your subconscious. So over to Dr. Shah.
Hello. Thank you everyone. Thank you, sir. I am Dr. Dvij Shah from Sankar Foundation Eye Hospital, Visakhapatnam. This year only I completed my DNB, so I am just new and very fresh for this talk. Thank you for giving me the dais for the youngs. This is just my observation in my residency period, and I think it will fit in Neuro-Ophthalmology. Eye as a window to your subconscious. We as ophthalmologists constantly have eye contact of the patient. By all instruments, we are observing different parts of eye on a micro level. So that is the reason ophthalmology should require a psychiatric concern. Eye is also so much expressive, and from the Indian culture and everywhere we are using in Bharatanatyam also, so where that eye is so much expressive. And as a all psychiatry patient with a headache, they are coming to ophthalmologists mainly all the time. So that social stigma is there, they are coming to ophthalmologists. So we need to find a way to diagnose that kind of patients also. So why is our eye so much expressive? Most of the movements controlled involuntarily, giving maximum space in the cortex. 90% of information transmitted to the brain is visual, and it is processed 60,000 times faster in a brain than other text. 40% of nerve fibers are linked to the retina. More than 50% of cortex and surface of the brain is developed processing visual information. So this much importance given in the brain for our visual impairment, and it is transparent not only for light, it is transparent for your emotions also. That it will come very fastly outside. These all are the information regarding eye. And the second reason is, as patients are not going to psychiatry, they will come to our specialty only. I will like to focus on the 4 components I have observed which can be linked to the psychiatry in our eye. First is pupillary reaction. Not just limited to ICUs and RAPD, pupils should be reacted to the reaction of the light. That basic rule is more the size, more the attention. If you are giving more attention, your pupil size will be dilated. That is a known fact. We can implement that in any scenario, mainly in online shopping. If front camera is on, we can see the pupil size, and if you are interested more, that product you are liking, you can use like that. Study has carried out closely related pupil size in different intelligence. So more intelligence, more pupillary size also for known fact. Extraocular movement. Looking towards the door outside. While in the talk, if you're looking constantly at the door, I should understand that you are not interested in the talk, you want to go out. So according to that, there are so many studies has done, and according to the eye position, we can find out if patient is telling truth or not. We can diagnose from that. If patient is telling he has used glaucoma medication, but he is saying down and saying, that means he is saying lying. So many facial expressions according to the eyes also they have known. Blinking and tear film already associated with the hormones and the psychological and psychiatry with the depression and the other related disorders. There is a dry eyes and associated with the psychiatric disorder already known. Eyebrows, micro expressions. According to the patient eyebrows, we can see micro expressions, and micro expressions are very known facts and used in the different kind of scenarios for the criminal. And it is involuntary movements of the muscle of the face occurs a reaction of any emotion, and we can find out on the eyebrows mainly. So that also we can use for the further implementation in the we can use with the psychiatry and the criminal to diagnose the criminal psychology. So my conclusion, I want to implement a new pioneer or something like requirement of a psycho-opth to study further with the other branches of the medicine. Increase, right now there is so many layers in the personalities of the market also, so that we can give in the market also some new branch, so that can lead to increase in the understanding of the patient, and both medical and commercially we can use this branch as a further new pioneer. Thank you.
Thank you so much, Dvij. That was a very interesting talk. I think in the next decade we'll have some ocular psychiatry coming up with you in the branch.
There is actually a lot of work going on, especially among dyslexic children, about eye movements, being able to assess their abilities, their fields, and try to enhance areas where they lack. So, absolutely, I think it's a very interesting talk. It really opens our mind through our eyes to look for things that may help us in the future. So, absolutely, thank you very much, Dvij. It was interesting, and I hope it leads to more research in our field. We are lacking good instrumentations that are specifically devised for neuro-ophthalmology. Thank you, Dvij. We'll go on to Dr. Pooja Hingorani. She'll be presenting a headache strain and ophthalmologist strain. Great.
Good morning, everyone, and thank you for having me. As I come from a multi-speciality hospital, I noticed that headaches, patients with headache usually go to an internist or a neurologist. So this is my case against that. So usually headache, as we all know, is a common universal symptom. It leads to a lot of absenteeism, loss of work hours. WHO says up to 40% of people do have headaches in their lives. But there are diagnostic issues, it's multifactorial, there are varied etiologies and classifications, and it spans around many specialities. So it's the internist, the neurologist, then the ophthalmologist, the ENT specialist, they have a claim to headache. Then there's a psychiatrist, the orthopedician, the dentist also. Now even the anesthetist, the neuroanesthetist and the analgesia specialist, they lay claim to headaches. So since most of them are benign, can be treated with minimal workup, but some of them can be vision and life-threatening, and they can present as headache. So they need to be diagnosed in time, and the patient himself sometimes doesn't know where to go to, whether he should go to the ophthalmologist or the neurologist. Usually these land up getting investigated too much of neuroimaging, CT scans, MRIs, where it could be as simple as computer vision or digital eye strain, or something as simple as a refractive error, uncorrected hypermetropia. So, but there are very limited studies which show what is the distribution of this pattern of referral. And there are ego issues happening in every specialty. Should we refer to the next specialty, etc. So, since we didn't find anything much on the net, we thought we'll do at least a pilot study before I come and speak about this to you to put forward my point. So we did a small pilot study spanning 2 weeks. In the first week, we saw the existing distribution. And the second week, we decided to send all patients having headache first to Ophthal and then refer them as required. So this is in short for this slide. So this was part 1 and part 2. So all patients, new patients coming to the screening OPD. Now in our hospital, there are 2 ways for new patients to come in. One is through the screening OPD, where the nursing officer gives chits and sends to the respective departments. And the second is through self-registration on the kiosk or the website. So there are 2 ways: the nursing officer decides or the patient himself decides. And then we see how many are referred to ophthalmology. Old patients or existing or known cases of glaucoma or other headache diagnosis were excluded. So we had this partly in the screening area and partly in the Ophthal OPD. As I said, first the patient came to screening. The nursing officer in the first week gave a token for whatever she was known to give for existing departments. The specialist saw it, saw the patient, and either treated or referred to ophthal. And some were directly referred to ophthal by the nursing officer. This second week, we said send all to ophthal. And then we saw the patients and we referred elsewhere if we needed, or we diagnosed. So we wanted to know the pattern difference also. So this is the first week statistics. The gender, well, a little bit of a female preponderance. 4% of all patients who came to screening, and around 1/3 came to screening, 2/3 came through self-registration. So, and this is a hospital with 32 departments. So 4% is quite a sizable number. So, and these were the patients we referred to other departments because they didn't belong to an ophthalmological diagnosis. So these were the three categories basically, those coming from screening, those who self-registered, and those who other departments referred to us, which incidentally happens to be very less. And this is what I want to stress upon. So here the screening staff decided, the patient decided, and in the third category, the specialist decided. So in the first, so this is the diagrammatic representation of that in the first week. So where the screening, patients came from screening, we saw that they referred only 17 out of 100 patients to ophthal in the first week. So that was very less, but amongst them, 75% did have an ophthalmological diagnosis. Amongst those who came themselves, 68% had an ophthalmological diagnosis, and we had to refer the others. And amongst those who were referred by the specialists from the other departments, all of them had an ophthalmological diagnosis. So this was in the second week. So percentage was around 3% this time. We had them all sent to ophthal. This is the comparative. There were no referrals this time from other departments. So 20 came as self-referred, 39 were from the screening OPD. There were some lost from between screening to ophthal department. I'll just talk about that. From screening, 52% had an ophthalmological diagnosis. Self-registration, 39%. This was week 2. And this is a comparative of where all we referred the patients in the 2 weeks. Now, this is what I would like to show. If we divide it, this is how it is, the division of how many had an ophthalmological diagnosis in the first week, and this is as per percentage. What I'd like to show is, in this case, those coming from screening, only 14% in week 1 of all screening patients got an ophthalmological diagnosis totally, because out of 100 patients. And in week 2, 54% of them had an ophthalmological diagnosis because they were all referred. So 40% are somewhere being misdiagnosed or not referred to ophthal for an ophthalmic cause. And in both the weeks, the patients who came themselves scored high, quite high. And the limitations of the study is that it's very small, the sample size. Tests of significance could not be applied effectively. Some days or weeks can be heavier in the OPD, especially after holidays and festivals, etc. And weekly holidays are, I just have 2 more slides, if you can please continue. But there was a dropout between screening to our OPD. We could see only elective and new presentations. We saw that the screening division was least accurate. Patient himself was more accurate, and possibly because he was more aware, he was more techno-savvy, and possibly he had more incidence of headache because of that, because of digital eye strain. We don't know that. That could be a confounding factor. And the specialist is the most accurate, but the least of the component. The specialist referring to ophthal, another specialist, is the least common. So there could be a bias. So overall, I would say, concluding, 50% patients were diagnosed to have ophthalmic causes of headache. The ophthalmologist's role is not only diagnosis and treatment, but also referral to others. And there should be a very strong referral to and fro established. Spreading awareness among patients can really help. Multi-speciality centers need to be developed, and eye-related causes are more common than brain-related causes. We tend to over-investigate headaches. SOPs need to be in place. We can have elective postings. In my institute, we've started elective postings in internship. We can have fellowships, centers with multi-speciality consultants, and international presence for headache in India, which is lacking. Only one person in India is registered in the International Headache Society. Headaches, first visit internist, very few get an eye referral, and we miss the glaucomas. We miss a symptom till it becomes a sign, and a latent error finally gets manifest. So it's time to see headache in the eye, quite literally. Thank you.
Thank you so much. That was very enlightening, and I agree that we tend to sort of underestimate the headache part, especially it's like no one's baby. But yeah, investigating more into it is very crucial. So,
Dr. Pooja, what was the most common cause of pure ophthalmic cause of headache?
So here in our case, it was the most common was refractive error, digital eye strain, computer vision syndrome. These were the most common. I have put them up, but I
Okay.
think
Right.
because of lack of time.
And which refractive errors were the most common? What age group are we looking at?
In pediatrics, we had the least referrals actually, just 3. And because there's a neuro pediatrician with us in the pediatrics department, so the least was for pediatrics, but this was for adults. There was
actually, that's why I said.
myopes, astigmatics, as well as hypermetropes.
Okay, and
We have a short stature in Maharashtra, so it's a little commoner than elsewhere with the taller people with hypermetropes.
okay, sure. Because I personally, at our center, I found it a reverse problem. I find that our neurologists keep referring us headaches, and essentially we're looking at, of course, the most common causes being orthoptic related problems, eye muscle
Orthoptic
problems,
also,
and to a modest extent, refractive errors, although, I mean, probably that's not the primary cause for them having a headache, but yeah, ocular surface disorders also with the periocular eye ache. But yeah, absolutely. We do need a little better understanding of headache as, a more localizing or an understanding value.
There
Thank
was
you.
also a trend towards having more PIs done, especially not in this particular pilot study. It didn't get documented here, but I had tried this before, and I asked the screening officer to send me more, and suddenly the number of peripheral iridotomies increased.
Yes, so
And one more thing, if you're dealing with children, actually we get more referral from the pediatricians. Just anyway, they will refer. We have seen any headache, they will refer to you, and you have to do a orthoptic workup. You have to do
Orthoptic,
a refractive error correction in that. That is more common. We have seen in our
So
centers.
we've seen that certain
And
pediatricians do
neurologists
that.
will be sending those cases, and even patients, they come to you with headache with other symptoms, you will yourself diagnose and have a referral. So these are the things, more of a headache which is going on, and ophthalmic migraine and all, these are all, there's a interrelated work which
I
should be
think
going
we'll
on.
take the discussion after we finish the session.
Sure,
Yeah.
sure.
Thank
Thank
you.
you
It
so
was
much.
wonderful talk. Yeah.
Thank you, sir.
So I would like to call Dr. Triveni Chimata. So basically, she is going to talk about demography and clinical analysis of traumatic optic neuropathy.
Good morning, fun and all. I am Dr. Triveni from NRI Medical College. Here I am going to talk on study about demographic and clinical analysis in cases of indirect traumatic optic neuropathy. Our aim is to analyze the demographic data, time of presentation, and the role of steroids in visual recovery of patients with indirect traumatic optic neuropathy. Under inclusion criteria, all the cases of indirect traumatic optic neuropathy treated between July 2021 to June 2023 at NRIGH were taken. Head injury patients with sudden loss of vision showing RAPD, normal fundus, and normal neuroimaging were taken into the study inclusion criteria. Under exclusion criteria, patients with open globe injuries, patients with traumatic parenchymal injuries, history of underlying neurological disorders, patients with other ocular diseases, optic nerve avulsion, cases of trauma presenting with signs explaining the loss or diminution of vision were excluded from the study. Coming to the materials and methods, it is a prospective study which was conducted at NRA Medical College and General Hospital. Duration of study is 2 years between July 2021 to June 2023. All the trauma cases attending the emergency department or cases attending the OPD was taken. We have no financial interest in conducting the study. Regarding the procedure, all the patients were clearly explained about the study procedure and informed consent was taken. It total 18, based on the inclusion and exclusion criteria, total 18 patients were taken into the study. Relevant ocular history was taken. History regarding the mode of injury, time of injury, and time of presentation was taken. History regarding wearing protective devices like seat belt and helmet was taken. Visual acuity was regarded as Snellen's chart wherever possible. Anti-segment examination was done. Complete pupillary examination was done, and color vision tested in patients with better visual acuity. Visual fields were done in patients with better visual acuity. Fundus examination by done bedside by direct ophthalmoscopy or slit lamp examination by biomicroscopy by 90D lens. Among total 18 patients, all were treated with steroids, and follow-up was done at 3 days, 2 weeks, and 3 months interval. Analysis is based on age, gender, laterality, mode of injury, either RTA, fall, assault, or other miscellaneous causes, presenting visual acuity, anti-segment findings, fundus examination, radiological findings. All the patients were given IV methylprednisolone 1 gram per day for 3 days, followed by oral steroids 1 milligram per kg body weight, which is tapered over 2 to 3 weeks period. And visual acuity was regarded as static, improved, or deteriorated. These are the pictures showing the results among the gender. Males, out of 18 patients, 16 were males, showing 89% male preponderance. And age group also more than 30 years of patients, 16 patients were there, showing 89%. Coming to the laterality, 69% of the cases are showing right eye involvement. And regarding the mode of injury, 17 out of 18 cases are due to RTA, and only 1 case is due to assault. And time of presentation, 12 cases presented immediately after trauma, 6 cases presented after 48 hours. And nobody has taken any safety precautions among these 18 patients. Coming to the anti-segment findings, 2 only showing subconjunctival hemorrhage, and RAPD is observed in all the cases. Presenting visual acuity, there are we have divided into 3 groups. One is 6 by 24 to 6 by 22 patients were there in this group, and 6 by 62 perception of light, 10 patients were there, and among 6 patients there is no perception of light is observed. And visual acuity after steroids, in 2 patients in the group 6 by 24 to 6 by 60, 2 of them have shown improvement, and with 6 out of 10 patients in 6 by 62 perception of light, they have shown improvement, that is 60%. And among 6 cases of no perception of light patients, only 2 has shown improvement, that is 33%. And 12 cases that are presented immediately after trauma, among these 8 have shown improvement, that is 80% of the cases that has presented immediately after trauma have shown improvement, and 2 out of 6 cases that have presented after 48 hours have shown improvement. And visual outcome is static in 8 cases, improved in 10 cases, and in no case it is deteriorated. This is a master chart showing visual acuity improvement. There is improvement of 2 to 3 lines of Snellen's chart in these patients, and among no perception of light patients, visual acuity improved up to CF3 meters. Coming to the discussion, indirect traumatic optic neuropathy is due to a closed head trauma that results in transmission of shearing force from forehead to the optic nerve in the optic canal or in the intracranial portion. It causes severe visual morbidity in the form of visual loss, RAPD, color vision defects, and visual field defects. In our study, clinical diagnosis is made by pupillary examination, anterior segment examination, and fundus examination. The average age of the patient is more than 30 years, that is 89%. Gender ratio is male to female is 8:1, that is showing male preponderance. The high male preponderance here was due to the fact that RTA is the major cause here, and which is the commonest cause of optic nerve injury, which occur more in males. Initial visual acuity ranges from 6 by 24 to no perception of light. All the patients have shown RAPD, and 67% of the patients had right eye involvement, which was also statistically significant. According to National Acute Spinal Cord Injury Study, early treatment with steroids within 3 to 8 hours of injury and continuing 48 hours were associated with better visual outcomes, which is similar to our study. And in our study, 56% of the patients had vision improvement after steroid therapy, which is similar results are found in other studies like Karmi and et al. The conclusion is there is definitely beneficial improvement in visual acuity with early presentation and with steroid treatment in cases of indirect traumatic optic neuropathy. Thank you once again for giving me this great opportunity for sharing the dais with the great personalities in neuro-ophthalmology. Thank you, one and all.
Thank you, Dr. Triveni. That was excellent talk. I think drawn is something which is very common. All of us do come across, and the observations that you highlighted that none of them were taking safety precautions is quite common. As regards the management, if the patients present early, majority of the physicians, treating doctors would definitely give a trial of giving systemic steroids unless until it is contraindicated. So one major contraindication we have to keep in mind that when there is severe head injury, because over there the long-term morbidity and mortality might be more, and in consultation with neurosurgery, if it is safe, it can be given. Otherwise, very high dose steroids are not indicated. And as regards our own experience, two observations I would like to add here is that not everyone improves. What is the I really don't have a definite answer that this is the predicting factor that this patient will improve, but possibly patients who have very poor vision at presentation are the ones who don't improve. And you might observe significant damage in the fellow eye also, like field defects, VEP abnormalities are quite common if we look at this. But we have to help and try to help these patients. This is my observation. Thank you.
Yes, sir, definitely. Thank you.
Yeah, so we'll move on to the next talk. Thank you very much.
Thank you.
We'll move on to the next talk. Yeah, Dr. Priyam Vada. So she's going to talk about MOG optic neuritis.
A very good morning, one and all. I'm Dr. Harika Priyamvada, and I'm here to talk on MOG optic neuritis. I do have a disclaimer. I am also a pretty new neuro-ophthalmologist, and my aim of my presentation is to increase the awareness of MOG optic neuritis in non-neuro-ophthalmologists, because many asked me, what is MOG at all? So let's see what is MOG at all. MOG stands for myelin oligodendrocyte glycoprotein. As the name suggests, it's a surface transmembrane protein located on the myelin sheath. Antibodies to myelin sheath, antibodies to MOG can cause the myelin sheath to fall off, and it causes demyelination. IgG1 antibodies are the antibodies detected in the MOG disease, which activate the complement pathway, and the complement deposition is seen on neuroimaging studies. How are these antibodies produced at all? Mainly by the autoimmune mechanism, since it's an autoimmune disease, but some studies say a precipitating attack like fever can also induce production of IgG1 antibodies, which cross the blood-brain barrier and cause an optic neuritis. So, MOG optic neuritis is an antibody-mediated autoimmune demyelinating disease of the CNS with a spectrum called MOG spectrum. It is a very distinct entity from the other demyelinating processes such as multiple sclerosis optic neuritis and NMO optic neuritis. Acute unilateral or bilateral, being steroid responsive, recurrent episodes of optic neuritis are hallmark of MOG optic neuritis. What does the spectrum consist of? The MOG consists of optic neuritis, encephalitis with brain demyelinating lesions with or without myelitis. Hence the term monim or MOGOD is used. But optic neuritis has been reported to be the most common presentation and manifestation of MOG spectrum disorder. So how do we differentiate between typical optic neuritis, that is MS optic neuritis, and the MOG or the atypical optic neuritis? Typical optic neuritis patients are usually present with unilateral, more female preponderance with variable visual acuity and visual field loss. They usually present with retrobulbar pain and a normal fundus, that is the retrobulbar optic neuritis. But MOG optic neuritis patients are usually present with bilateral rather than unilateral, or unilateral can also be present. According to our recent research, we found unilateral presentation causes more recurrences in MOG optic neuritis. There is no gender predilection, or some studies say males have a preponderance of MOG, and it is mostly associated with optic disc edema rather than the retrobulbar optic neuritis. The acute vision loss ranges from around 20/40 to counting fingers or even PL negative, but the prognosis is very good that after treatment they improve to 20/20 also within a month. So the loss of color vision, RAPD, are similar in both the conditions. Why are we talking on MOG at all today? Because according to ONTT trial and the Western data, the prevalence and incidence of the multiple sclerosis is more, but after the era of biomarkers, the incidence and prevalence has changed, especially in India and Asian countries. The prevalence of MOG is 28%. So the clinical features are children and young adults can be affected, and any age group can be involved with acute vision loss. Bilateral most common, and can be unilateral or recurrent in the other eye, or which we call as sequential. With they can present with papillitis. They have excellent response to steroids, recurrent episodes, and they are associated with myelitis and encephalitis. So they may have associated seizures, dysarthria, encephalopathy, and limb weakness. So ADEM like features can be present more commonly in children. So MOG is increasingly recognized in the pediatric population, and suspect MOG in case of new onset of seizures or sudden regression of milestones. We have cases or instances where we have seen children presenting with vision loss and encephalitis together, where vision loss is just ignored and encephalitis is completely evaluated for everything including Lyme disease. But later on, when they presented to us after 3 or 4 months, we did a MOG test and the MOG is positive. So MOG is such important, especially in the pediatric patients. Children from 1.5 years can also be affected. So how do they present? They present with grade 1 to grade 4 papilledema, any grade of papilledema, or they can present with temporal pallor or disc pallor in the other eye, especially in recurrent cases. So HVF, according to ONTT, any type of field defect can be present. Similarly, in MOG also any type of field defect can be present. In acute presentation with a higher grade of vision loss like counting fingers and all, they present with advanced field loss. On OCT, we look for disc edema and RNFL thickness above more than 125 is considered as true edema. And on MGCL, that means ganglion cell thickness, in the initial presentations it could be normal, especially in the first episodes, but most of the patients presents with a thinning of ganglion cell layer, and the GCL thickness is very low, less than 80. On OCT angiography, there can be a rare fraction of peripapillary capillary density in left eye. In the affected eye. MRI findings, let's see what is a normal MRI at all. Sir, can I continue, sir?
Yeah, you still have.
Okay, so this is a normal MRI showing a T1 image with the optic nerve and fat around. This is can you see the pointer? Yeah. The T2, this is a T2 image, the axial sections showing the normal optic nerve and the CSF, normal CSF fluid around the optic nerve. This is a fat suppressed T2 image. This is again a T1 image which is with fat suppression. Okay, this is the coronal image. Just observe the color difference between the optic nerve and the muscles, because that is important. I am going to tell. This is the whole optic nerve this is the intraorbital part, this is the intracanalicular part, intracranial part, and the intracranial part. This is the chiasma. This is just the tactography. So what will we see on MOG optic neuritis? We do see hyperintensities of optic nerve on T2 weighted fat saturation images. This is the T2 weighted fat saturation images with long segment involvement of the optic nerve and have hyperintensities. These are confirmed by the enhancement of the optic nerves on T1 contrast imaging with the gadolinium. Fat stranding is also specific for the MOG disease, and optic perineuritis is also specific for MOG disease. So yeah, this is the similar depiction of long segment involvement and the perineuritis involvement. MRI brain non-specific white matter demyelinating lesions are more common. Normal MRI is also common. MRI spine, there could be a swelling of spinal cord and contrast enhancement similar to transverse myelitis findings. These are our patients presenting to us with a thoracic lesion in the spine, and involvement of conus medullaris is most common in MOG. So you can take a picture of this, which differentiates the features of MOGAD, NMO and MS. So how do we diagnose the serum analysis? We do a serum analysis. Cell-based immunofluorescent assays are often preferred as it is more sensitive and specific and the current gold standard for diagnosis. It is very recently, it is the MOG antibody detection has been started only or discovered in only 2007, and hence it is very new and is less available in the smaller cities especially. Contrary to the seropositive aquaporin 4 serum antibodies coexisting in ant MOG syndromes, only 9 related autoimmune conditions are found in over 1/3 of aquaporin 4 IG seropositive NMO cases, but only in 9% of anti-MOG syndromes.
Can you
Treatment
wind up?
IV.
Can you wind up?
Yes, ma'am. Treatment, we give IV methylprednisolone for 5 days, and for maintenance we give azathioprine, MMF and rituximab. So it has good prognosis, and the differential diagnosis are NAION is also an important differential diagnosis. So yeah, this review article confirms the data is different from in India from the West. Thank you.
Thank you. That was great, and I know it is short of time, but it is an extensive topic, and I think it's very important, and especially in our population, the awareness of MOG optic neuritis definitely needs to be disseminated.
Sorry for taking more time, ma'am, and I thank AIOS for giving me this golden opportunity to talk in front of legendary neuro-ophthalmologists. And thank you.
There
for
are
your
no
kind
legendary
intention.
neuro-ophthalmologists. We are all still in the process of learning and acquiring. Neuro-ophthalmology is a very nascent and young specialty.
Yeah.
And I'll just take this opportunity to invite all of you. We are holding the annual Indian Neuro-Ophthalmology Society meeting at Hyderabad on the 9th and 10th of December. That will be a place where all young and old, not necessarily experienced neuro-ophthalmologists will be coming together, and we have a host of international faculty to give us some insights into this emerging understanding of a very complicated disorder that requires, I guess, understanding from all of us. So thank you, Dr. Premada.
Yeah, so we'll move on to the next presentation. So Dr. Divya Tirumuru will talk about prognostic factors of isolated oculomotor nerve palsy.
Good morning,
This
everyone.
is the last talk, and if time permits, we can have a discussion.
I am Dr. Divya from NRA Medical College, Guntur. So today I am going to speak about a study done on a prospective observational study done on a prognostic factors of isolated oculomotor nerve palsy. So oculomotor nerve is a third cranial nerve. It is totally motor in its function. It supplies the extraocular muscles like superior rectus, inferior rectus, inferior oblique, medial rectus, along with levator muscle, and some intraocular muscles like sphincter pupillae and ciliary muscle. So third cranial nerve had different types of presentations. It may be acquired or congenital. It can be pupil sparing or pupil involving. It can be a complete palsy or partial. It can be isolated or associated with other cranial nerve palsies, starting mostly from 1st to 8th cranial nerves. And most acquired cases are due to microvascular ischemia, that may be due to diabetes, hypertension, etc. And other causes may be intracranial aneurysms and head injuries. The diagnosis and treatment of this nerve palsy varies according to its etiology and modes of presentation. Third cranial nerve palsy due to microvascular angiopathy is usually pupil sparing in its presentation and has high chances of complete recovery. But whereas those due to traumatic or compressive lesions like tumors and aneurysms, they may not resolve completely and may also show signs of aberrant regenerations. And the aims and objectives of the study were to analyze the etiology of the third nerve palsy, various clinical presentation, and to assess the recovery in these patients. Inclusion criteria, all the acquired third nerve palsies were included, all age groups and sexes were involved, and only the patients who have given consent were included in this study. And exclusion criteria, congenital cases we have excluded, and patients with other cranial nerve palsies also we have excluded, and those who have not given consent and uncooperative patients were also excluded from the study. And all the cases were collected from those presenting directly to the Department of Ophthalmology or those referred from other departments like neurology and neurosurgery, and the study was carried on from January 2021 to May 2023, and we were able to collect 30 cases. So all the patients' data and demographic details were collected and documented, and history was obtained mainly regarding the duration of onset, pain, head trauma, and presence of any systemic diseases like diabetes, hypertension. And the patients were carefully examined for extraocular movements, the pupillar reflexes, and a neurologist opinion or neurosurgeon opinion was taken for all the cases along with a CT scan or MRI brain including the orbits. And all the patients were followed up to 6 months, and the results were tabulated accordingly. And this is a prospective observational study, and there was no potential risk involved to any of the patients. And all the results have been expressed in the form of percentages, and probability indices have also been calculated. And we had no financial interest in this study. And these are my results. Maximum age group was between 51 to 60 years, that is 30% of the cases. And females were more commonly involved than males, and left eye was more than right eye. And the pupil sparing cases were 60%, and 40% of the cases were pupil involving. And these are different etiologies. So microvascular ischemia outstands all the causes, 19 cases, so 63%, and 5 cases were because of trauma, 3 cases were idiopathic, 2 were miscellaneous, and 1 was due to demyelinating disease. And complete palsy presentation was seen in 33% of the cases, and whereas in the rest of the 66% it was partial. And patients have complained of pain during the presentation in 43%, and 56% it was absent. And these were the recovery rates calculated at 6 months of presentation. Out of 19 cases of microvascular ischemia, 9 cases have recovered completely. 5 cases have shown partial recovery and 5 cases did not recover. Out of total 5 cases of trauma, 1 case has recovered completely, 5 had partial recovery, and 2 did not recover. And all the 3 idiopathic cases also did not recover. And miscellaneous cases, 1 had shown partial recovery, 1 did not recover. And the 1 demyelinating disease also did not recover. And these were the different recovery rates in different conditions. Complete palsy has shown only 30% of recovery rate when compared to the partial palsy, where the patients have shown 75% of recovery rate. And p-value was calculated here, which was less than 0.017. And in pupil sparing cases also, there was a significant improvement where it was 77%. Here also the p-value was significant, that was less than 0.0149. And when ischemic and non-ischemic causes were compared, there was a significant recovery that was up to 73%. And the p-value here also was quite significant, less than 0.04. And when trauma and non-trauma cases were compared, there was no much difference. So the p-value was 1, which was insignificant in these cases. Finally, concluding, the microvascular ischemic causes and pupil sparing cases and incomplete palsy were considered to be significantly important for the recovery of third nerve palsy. So concluding this study, the most common cause of isolated oculomotor nerve palsy was microvascular ischemia, which was seen in 19 cases in our study and which can be easily diagnosed and managed. Trauma was the next common cause. 50 to 60 age group were the most common presenting patients, and females more commonly affected than males, and left eye was more involved. And ultimately microvascular ischemia, incomplete paresis, and pupil sparing palsy had high chances of recovery. These are my references. Thank you.
Thank you so much for a wonderful talk and the study and the analysis that you did. So I think we have 5 minutes. So if there is any comments or questions.
Yes, please.
For optic neuritis. So I think there is no hard and fast cutoff time, but at the same time that response might be most beneficial if it is given within 10 days of the onset. Though I think all of us have treated patients who have come to us later, 3 weeks, 4 weeks also, and if there was active enhancement, patients have responded very well.
So it also outcomes matter depending upon finally what is the diagnosis. Like for a typical demyelinating optic neuritis, whether it's a part of MS or it is a clinically isolated syndrome, the earlier ONTT concept was that even if you don't treat, they're going to go and become normal. Now this concept has completely changed, because if you delay or do not give steroids in patients with MOG or NMO, then the final outcomes are very, very poor. So now we have essentially shifted that we are aggressively giving steroids, and of course you need to rule out any other cause, you need to rule out any active infection, you need to rule out any other disease that can flare up, like tuberculosis is one of the things. So if there's a concomitant tuberculosis focus, those are things that, and electrolyte imbalances. So now we are treating more aggressively. If the patient starts responding, natural recovery as is seen in optic neuritis, if the patient by 2 or 3 weeks, we expect the visual recovery to start spontaneously improving. If that starts happening, then it's sometimes debatable, because you're thinking that it's likely to be typical and therefore possibly demyelinating. We sometimes withhold our hand on steroids, again depending upon the background of the patient and how, if there are likelihood of side effects. But otherwise, we are now tending to err on the side of giving IV methylprednisolone if we are fairly strongly sure that our diagnosis is optic neuritis.
Possibly also we are shifting also to giving prolonged taper of steroids rather than what was initially given in ONTT. So I think
So
Dr. Rohit will
exactly
address.
as was mentioned by Dr. Virender, if we have to actually differentiate between demyelinating typical optic neuritis versus non-demyelinating, either due to NMO, MOG. So even if there is a slight atypicality in the presentation, you think in terms of a non-demyelinating optic neuritis, and in those conditions we are often treating for a much longer period, because the outcomes, the risk of recurrences, these are so much more. So we are, as I said, now more aggressive in treating with steroids rather than with not. So nowadays our thought process that if you don't treat, your final outcome is going to be the same, is only valid or only true for a demyelinating optic neuritis if confirmed. That's one of the important things that we need to remember. But again, bottom line, remember, no infections, no electrolyte imbalances, no possible TB lesion that the patient may have which can flare up. So these are downsides of steroids, and we must be careful. We are giving IV methylprednisolone so frequently that we forget that at our center we have had a death with IV methylprednisolone because of electrolyte imbalances which were not known prior, and therefore it is very, very important. So cautious treatment with IV methylprednisolone is must. Can't indiscriminately without coming to a diagnosis. So we're treating a diagnosis of optic neuritis because of demyelination or a form of inflammation of the optic nerve, but it's not the treatment that even if we don't understand the case, we can think in terms of. That's the most important, I think, lesson we must all remember. First step is to be sure that it's an optic neuritis. Absence of relative afferent pupillary defect, the no significant abnormality in the other eye. So other eye testing, if one eye is significantly affected, the other eye workup is far more important. I need to make sure I have a normal field so that I'm not looking at a space, a cranial space occupying lesion or some cranial lesion. Then sudden onset loss of vision that can be ascribed to the optic nerve. So presence of vision loss along with an RAPD which is in consonance with the severity of the vision loss, mild ocular pain, sudden visual loss setting. These are all classical signs of optic neuritis. And this would be if, as I said, if you rule out any systemic infections, if you rule out any other cause per se, no, you need to dilate all these patients and see. Sometimes we've missed a peripheral, a uveitis, an intermediate uveitis that can present with mild disc edema, and we give them steroids and they get better, and then we stop the steroids and they come back with a recurrent uveitis. So a comprehensive examination is a must, so that you're able to localize that this is an optic nerve problem, and imaging that will show enhancement of the optic nerve with or without MRI brain changes. And then if that falls into place, you can start IV methylprednisolone, and depending upon if there are any other neurological features and anything else, you can think in terms of working with a neurologist for future management. I would say is the clinical practice we all do. That's how, I mean, very often, because it's a clinical diagnosis, optic neuritis has to be comprehensively worked up before we are, closer to the diagnosis and start our management. Any?
I think we're almost to the end of the session. It's 10:30. So I'd like to thank everyone for participating in our session, and I'd like to remind that we have the INOS, the Indian Neuro-Ophthalmology Society meeting in Hyderabad. It is in South India. It's very close to you all. So please attend, 9th and 10th of December.
It's just inosindia.com that you can just go. Abstracts are still open, and truly we have a very, very interesting session for all levels, as I said, young, old, experienced or not, for neuro-ophthalmology. Thank you everybody for coming to this neuro-ophthalmology session. Can I invite the speakers? We can have a quick photograph to remember excellent neuro-ophthalmologists from this part of the country.